Good evening, good morning, good afternoon, everybody. It is 5 minutes past 7 p.m. in Paris, 5 minutes past 7 in Barcelona, 5 minutes past 8 in Jerusalem, 5 past 1 p.m. in New York, and last but not least, 5 past noon in Nashville. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris in France. And it is my great pleasure and honor to welcome you all to this very special journal club by the International Academy for Clinical Hematology. Today we have chosen not an original work, because as you probably know, the principle of the journal club is to choose an original research paper and to discuss it with a co-author and an external expert. But we've seen recently a lot of discussions and controversies about the role of CAR T cells in early relapse in DLBCL. And this is about the results of the Transform, ZUMA-7, but also Belinda trials. And interestingly, our colleagues from the US, Dr. Perales, Dr. Anderson, Dr. Jain, Dr. Kenderian, Dr. Oluwole, Dr. Shah, Dr. Sovoda, and Dr. Amadani did a terrific sort of a review published in TCT recently with a sort of a Q&A and trying to critically assess the content of these trials. Because as you know, CD19 CAR T cells have been shown to be highly effective in the relapse refractory DLBCL. However, the randomized phase 3 trial that I have mentioned a few seconds ago, conducted in second line, actually compared the same CAR T cell construct to the current standard of care, namely autologous stem cell transplantations. Two trials, Transform and ZUMA-7, showed improved EFS, event-free survival, in patients treated in second line with CAR T cells. But the Belinda trial wasn't a positive trial. And of course, when you have two positive trials, one non-conclusive trial, obviously there is room for lots of controversies and lots of questions. And actually, we started receiving a lot of questions from colleagues about how to proceed, especially when it comes to those patients who are in early relapse of their disease. And this is why I'm very grateful to you, Miguel. You are the first author of the work. To you, Dr. Oluwole from Nashville, where you have contributed to the work. Unfortunately, the other colleagues couldn't make it, in part because of this COVID re-emergence, I would say. I'm very grateful to Dr. Anna Sureda, president of the European Society for Blood and Marrow Transplantation, top expert in this field, and who will give also the European perspective on these trials. And of course, very grateful to my friend and co-chair and colleague, Professor Nagler, who has been also involved in this field for several decades. So my first question to all of you guys today, and actually I'll bring back into the table the question that were asked in this work published recently in the journal TCT, And this is about what you today, guys, consider as the current standard of care of patient with DLBCL in second line. So first line, you relapse, and you may wish to give me different scenarios. Let's avoid discussing the randomized trials because that's going to come in other questions. And of course, maybe I'll give the priority to answer to Professor Sureda, ladies first, unless there is another volunteer.
Thank you, Mohammad. So I think that if we forget about randomized prospective clinical trials, and on the 19th of July 2022, at least in our center, the standard of care is still autologous stem cell transplant. So if you have somebody with primary refractory disease or with relapse, let's say early or late relapse, I'm sure that later on we are going to focus on early relapse. If the patient is able to achieve a complete remission or a good partial remission, we are taking this patient into an autologous stem cell transplant. So that's still our standard of care. I'm sure that the standard of care is going to change, and we will be discussing that. And maybe I will be able to mention, let's say, the new edition of the BMT indications manuscript, where the standard of care that I am mentioning now, it's not written there. So it's a different standard of care. But for the time being, we are still autografting these patients.
Excellent. Thank you very much. Arnon, today, if you have a 55-year-old gentleman coming to you for a second opinion after relapse, first relapse, second line treatment of DLBCL, what would be your recommendation to this patient?
So I think it's depend. I mean, I would say that in our center, still autologous transplant is standard of care. But as you know, we have an academic in-house program in which we use in-house CAR T cells for 150 patients already. And we amend this based on the randomized study. We amend this trial that can include now CAR for the second line. It also depends on the comorbidity of the patient, and also if the patient is born in our center or he came to our center after getting some kind of salvage therapy for the relapsing lymphoma and has a partial response or chemosensitive disease. So I would say that still for me it's autologous transplant, but my lymphoma colleague not always agree with me. And for patients that have, of course, high comorbidities, we may subject the patient for CAR T cells, but this will change and the floor is also changing. So the patients prefer CAR T cells than autologous transplant, and the community also press for CAR T cells. But so in view of the papers that we all know of, Hamadani in Blood 220, dissecting these patients as for the response and PET-CT, I think that there is, of course, will be a room for autologous transplant, but the field will change and the number of autologous transplant in non-Hodgkin lymphoma are going down.
Excellent. Thank you very much. How is it today in Nashville, Olale Khan?
Oh, thank you very much for inviting me. So we are adopting the modification of the FDA label for the axicabtagene ciloleucel, which will be in second line in those who relapse within a year of frontline therapy. So that has become what we are doing here in Nashville. That said, autologous stem cell transplant, we still do that. Because there are others who may progress after the 12-month period, and they will not be eligible based on the label indication. If we started them on a salvage therapy with an intent to do autologous stem cell transplant, if they respond, if they do respond, they get really good results with autologous stem cell transplant. So I agree in part with my European colleagues that there is still a place for autologous stem cell transplant.
So just to clarify this, because it looks to me that you try to be politically correct, saying on one hand, you adopted the label granted by FDA for this construct, but on the other hand, you think there is still room for auto transplant. So I would ask my question about this 55-year-old gentleman, no comorbidities, who really trusts you and who is in first relapse at the 13 months after first line.
Thank you for making the question very specific. So after 13 months from the first therapy, he will not be eligible for CAR T. He will be receiving salvage therapy. And if he demonstrates chemosensitivity, we'll get autologous stem cell transplant, which is what we actually do right now in Nashville. The issue are those, the same gentleman, if he relapsed 2 months earlier.
11 months?
Yes, he will be a candidate for CAR T, or if unfortunately, as sometimes happens, almost half the time, salvage chemotherapy may not get good disease response, and that would also have CAR T written all over it.
Okay, Miguel, how is it in New York? And I'll slightly modify the features of the patient because he is 60 and he has a couple of comorbidities, actually, not big ones, you know, a little bit overweight, some diabetes.
I think, you know, we're obviously we've adopted the, you know, change in FDA label, which is now both for axi-cel and lyso-cel. And actually, interestingly, the NCCN guidelines were modified in March already for axi-cel and second line before the FDA actually changed the label. So the NCCN had already pronounced itself before the FDA approval in second line. I will say that when it comes to patients with comorbidities, the patients that you describe is probably eligible for auto transplant. But if you had told me an 83-year-old patient, you know, who is a little bit frail, I actually would have done CAR T cells last year before even, you know, having FDA approval in second line. In fact, I did CAR T cells in a couple of patients in 2021, women in their 80s, who were referred for autologous transplant, but instead we did CAR T cells in second line because we felt that was actually safer. And one of them is still doing quite well and is in complete remission. One of them unfortunately relapsed. So I think, you know, our standard of care today has definitely changed. And we're now doing CAR T cells in second line, but there are obviously many scenarios that we can discuss that sort of can impact that. The 12-month issue, I think, is one of them. The question I have is how many of us are going to start doing CAT scans or PET scans at 11 months so that you don't end up with that patient who has a scan a few days after 12 months and then is no longer on the FDA label. So we may see more scans being done just before 12 months. And then there's a whole debate that we address in the paper about when does the clock start for 12 months? Is it sort of 12 months from diagnosis or 12 months from end of treatment? And obviously between the CORAL study, which was 12 months from diagnosis, and the clinical trials, which was 12 months from end of treatment, there's a 3-month window. And if Mehdi were here, he would argue that that 3-month window is actually relevant, and that patients who relapse, 12 months from treatment actually do quite well with auto transplant and should still get auto transplant.
So that brings me to a slight question, and just to make sure that we are in agreement, I do appreciate that a label, you need a number, and then it has been 12 months. But I believe that from a scientific and medical standpoint, I think we all agree that there's no such significant difference between 11 months and 13 months, or even 15 months. You know, if today in 2022, a patient who relapsed with DLBCL at 14 or 15 months, I wouldn't consider this as a big success. It's still, I think, an aggressive disease. So, okay, all of you have mentioned these famous Transform, ZUMA-7, and Belinda trials, and they are quite impressive trials. 865 total number of patients included, 359 on the ZUMA-7, 322 on the Transform on Belinda, and 184 on Transform. So Anna, I'm back to you. What are the key teaching for you as a lymphoma expert? And let's forget about the label now and the scenario of my patient who needed treatment. But what did you learn from these trials? I mean, it's not the first time in our field where you have phase 3 trials leading to divergent results. Still, we managed to cope and to handle and to come to a consensus. So what are the teaching, and what would be your final conclusion from the 2 positive, 1 negative?
Well, I think that the first conclusion is that the 3 trials are not exactly the same, and this has been very well analyzed and dissected in Miguel's analysis or in this consensus study. So I think that to understand the results of the trial, we have to really analyze the small details in each one of the trials. So we have 2 trials which are positive, 1 trial which is negative. I think that there are a couple of reasons to understand why this trial has been negative. We can think about disbalances of the population of patients included in both arms. We can think about this famous event-free survival definition, which was quite tricky. I have to say, the fact that the patients included in the standard of care arm, many of them received 2 different lines of salvage chemotherapy, which is one thing that in our daily life, we are usually not doing that normally. Although, let's say, it was mimicking in some ways, data taken from the patients included in the CORAL trial. From my point of view, the most important aspect is the super big vein-to-vein time, or the manufacturing time, which was significantly longer in the Belinda trial in comparison to Transform and to ZUMA-7. And for the population of patients that were included in the trial, early relapses and primary refractory patients, probably this manufacturing time that also impacted in the standard of care arm, just because of the definition of event-free survival and the possibility to continue treatment in these patients, I think that at the end of the day selected really a bad population of patients for those included in the arm. So that would be, let's say, my reading from the negative results of Belinda. Maybe other people can add additional things. We have 2 positive trials, and let's say with, understanding the differences between these 2 positive trials, they compare CAR-T with a package of salvage chemotherapy plus autotransplant, and maybe we can discuss in length about the designs of the trial as it has been discussed in the paper. But with this specific comparison, the 2 trials demonstrated that in this population of patients, CAR-T were able to offer significantly better event-free survival, with quite a decent follow-up for ZUMA-7, shorter for the Transform trial, with benefits in terms of patient-reported outcomes, which is really very important. The toxicity profile was not so different from what we know as using these constructs as third-line treatment strategies. And I think that because of that, then we can discuss patient profiles and other things. The standard of care, Ola and Miguel have already mentioned that, and Arnon also in the setting of prospective clinical trials, but I think that in Europe, the standard of care is going to change. We may discuss how much this new standard of care is going to be adopted in light of that not every single center is accredited for CAR-T, availability of CAR-T, what happens in those patients that achieve a complete remission if they receive salvage chemotherapy. But I think that the standard of care will change quite soon.
So Arnon, it looks like when you spoke initially that auto transplant is still well established in your center. So what are the additional data you need to convince you to move, to switch, like it is the case in Nashville and New York? Because it looks to me that they have a more liberal adoption of CAR T cells. Obviously, access, reimbursement is an issue, but I'm not convinced 100% that it's only about this. There's also a culture of transplant, which is much more stronger, I would say, in the European environment compared to the US environment. At least this is my understanding. What do you think?
I mean, from a medical point of view, you know, it's a big, for me, artificial or surprising. I mean, I would say that CAR T cells revolutionized the field of lymphatic malignancies. And no question that this is major breakthrough, the most important breakthrough in the field. And no question that this will be, at the end of the day, immunotherapy and the CAR T cells and other, the way that we will treat our patients. For me, it's a bit speaking for the design of clinical trial, you know, that let's say T-cell cell that is similar in daily activity, maybe less than axi-cell in some ASHP, you know, abstract but not well designed, will not be approved because a major difference in the studies. You know, the time to production, the allowing or not allowing bridging therapy, is the bridging therapy calculated as salvage therapy or not, and all other issues that, you know, 12 months from diagnosis or end of treatment, and some other crossing over, and is the crossing over in the study or out the study, and is the bridging or just glucosteroids. So it's strange that this product, which seems to be like the other, will not approved because the study design is different, which speak for the way that we approve the drugs today, you know, because I think that for me, if both other product is approved, T-cell cell need to be approved. Other issue is, of course, that not every patient and not every center that we want to give to the patient CAR T-cell can give it today. So I think that these are the consideration, and yes, the CAR T-cell as second line will be the standard of care for this patient, and for some of the patients, we will argue that still they can go autologous transplant, but this patient, when we will discuss with this patient and they will go to second opinion, I'm sure that they will come to us and say that they want CAR T cells because the second opinion told them that yes, they can go autologous transplant, but CAR T cells will do the same for them. So.
Okay, thank you very much, Anand. So, Ola, let me a little bit dig deeper into these trials. One of my old masters used to tell me that when you do a randomized trial, if you want to win, either you have a control arm which is very weak, and then your experimental arm may win, or you have an experimental arm which is very robust, very powerful, and actually you don't care about the control arm. It will always win. It's like, you know, sort of imatinib, you know, in CML. Targeted therapy, you give it molecular remission and whatever you put in front. So that brings me, the problem here is that all three trials use the same control arm. So we can't blame the control arm for being weak or insufficient. Then the three trials used CAR T cell construct, which of course we can still argue, but where we believe they work rather good. So this is, you know, against the dogma of my old master, you know, where you can win either with the experimental or with the control arm. So here, and I think Anna alluded to this, it's maybe about the way the trials were designed. You know, there is a trick somewhere where, you know, one ended up positive and the other one ended negative. So my question to you, where do you see, and I'm not making any judgment, the positive or the negative bias in these trials when it comes to this famous treatment package that was mentioned by Anna?
Yes, I think Dr. Sureda mentioned a fair amount of the nuances in the designs. And, you know, I think about the clinical trial sponsors, similar to somebody who has a horse in a race. They're gonna wanna do everything for their horse to win. Of course, within the rules, or I'm not talking about just within the rules to make their, and that would be very legitimate. So I think it is reasonable for some of the trial designs, even some that have been criticized. For example, why choose EFS? Why not PFS? But then EFS will report quicker. You want to get to know that this works. You want to get it out there to those who do not. And they built in crossover. So there is really no denial of therapy based on an event. So I hope you're hearing from me stating that whereas some of these criticisms are very legitimate, the contingencies that were built in were also of good faith from the investigators and the sponsors. Another one that Dr. Sureda didn't mention was the use of bridging therapy in the lysocell arm. That has also been talked about a lot, that, okay, if these ones are in the CAR-T arm, why are they getting a cycle of pretty good chemotherapy? You know, that will reduce the disease burden. That will make it safer for and easier, more tolerable for the CAR-T experience. And that helps to mitigate the risk of a prolonged time to manufacture. And it is really hard to argue against some of these designs that will aim for optimization of patient safety. I think that would be my short-winded answer to your question.
Excellent. No, I think you have answered in a very precise and honest, scientifically valid way. Thank you very much. I'm very grateful. So Miguel, we heard the controversy, the different issues, the pro and con, the design of the trials. But then there is an argument at the end of the day. If I just forget about all of these small details, you know, being how to fine tune a trial to win or to lose, someone may come to you and give you the bigger picture and speak about the hard endpoint. And the hard endpoint in oncology, in cancer, is about overall survival. And then in these trials, there's no overall survival difference. And then how, at the end of the day, the goal is to live long and well for a patient. At least if I'm a patient, guys, that is my objective in life, and for treatment. Live long and well. I don't care about the scientific arguments and debates. So how would you justify, because it looks like to me that you are adopting a liberal approach, looking, and many colleagues, and they may be right, I'm not criticizing them, that everybody's going to look now at 11 months for the PET scan and see something there, with an SUV, and start the debate. But at the end of the day, there's no overall survival advantage. So why bother with this?
So a lot of questions there. I guess one comment I will make is at least the trials didn't use chlorambucil as a control. So the control arm was legitimate. I think the issue is about overall survival. So both positive trials actually do show a difference in overall survival at the time of presentation and publication, but they have not reached statistical significance. And so we'll have to wait for longer follow-up to see if that overall survival difference is seen and becomes statistically significant. So I think that's one point. I think the issue is, the crossover actually, which in Belinda and Transform was built into the trial, but in ZUMA-7 was not, was actually very similar in the 3 trials. So it was around 55%, and even on ZUMA-7, around 55% of patients crossed over, mostly to commercial CAR, axi-cel, but some crossed over to experimental CAR. But so you ended up in a similar situation in terms of crossover. And so in trials in randomized trials where you see a difference in EFS and no difference in OS, then the question is sort of, do you treat now or treat later? And we could sort of get into the whole, myeloma transplant now, transplant later debate, which I'm sure you have much more to say than I would ever have to say about. But at the end of the day, as the treating physician or speaking to you as the patient, as you said, wouldn't you want the best treatment first? Because if you get the CAR and that gives you, similar overall survival, that's going to be at the expense of less treatment. There's less chemotherapy, even if you do get, a cycle of bridging as was used on Transform, and we're actually using quite a bit now with axi-cel. You're not getting the auto transplant. The risk of secondary malignancies that we see with auto transplant is probably much less with CAR, although I'm sure there is some. But we have to remember the risk of secondary malignancies that we're seeing with CAR that is reported today is all in patients who've had prior auto transplants. And so the component and the contribution of the auto transplant to that risk of secondary MDS, for example, is hard to tease out. So I'm going to assume that the risk of a secondary MDS coming out, in second-line CAR is going to be lower than auto transplant. And so I think those are important considerations. I think the quality of life studies are very clear. The return to baseline quality of life occurs much earlier with the CAR arm than with the auto transplant arm, and that was reported at ASH for both axi-cel, ZUMA-7, and the Transform. So they both had presentations on that topic. And I actually presented at the Tandem meeting a late-breaking abstract looking at cost effectiveness. And in the US, at least, ZUMA-7 showed that CAR T cells were cost effective and met the quality criteria for cost effectiveness in favor of the CAR. Now, one of the critical assumptions that was made in that cost effectiveness analysis was that the overall survival would be maintained. And obviously, when you look at cost effectiveness over the lifetime of the patient, the overall survival is going to be one of the main drivers of a cost effective drug. So obviously we have to see how that translates into the real world. But I think there's many considerations that would argue that in the presence of an event-free survival difference, even in the absence currently of significant differences in overall survival, that may be, indications that that may happen, I would favor using what we think is the best treatment up front and not saving it for later.
Excellent. Thank you very much, Miguel. That was very clear. Anna, because you're president of the EBMT, would you consider this risk of secondary malignancies, which we know in lymphoma is higher than in multiple myeloma, actually, as a sort of an argument to avoid auto transplant whenever possible compared to CAR T cells?
Well, I think it's one of the arguments, and I would fully support what Miguel has said. So, I mean, we are looking at OS, but OS, it's always impacted by third-line treatment strategies, like in this case. If I would be a patient, of course, I would like to live as long as possible with a quality of life. But if I can be cured with second-line treatment strategies, much better than if I have to go into a third round of treatment with all the long-term side effects. And of course, secondary malignancies is a very well-known side effect of high-dose chemotherapy and autotransplant, although I think that we are not able to clearly dissect which is the impact of the prior chemotherapy that the patient has received in the overall incidence of secondary malignancies. That's one thing we have to take into consideration. And of course, we need longer follow-up of patients being treated with CAR-T to better understand which are going to be the long-term side effects of this new treatment strategy. But I think that it has to be considered, of course, amongst other things. Let me say one thing, Mohammed, because I think I'm moving a little bit from your question, but one of the things that these trials are showing us is how kind of consistent is the standard of care arm. So if you look at event-free survival of the standard of care arm, the median EFS is quite similar. And the other thing, which I think is very important, is that, and this is also quite consistent, not exactly with the CORAL trial, because patients were not evaluated with PET-CT, but with CT before autotransplant, but with the ORCHARD trial, that only 30-something, 35, 36% of the patients reach the autologous stem cell transplantation. So in this sense, we are not talking about CAR-T here, but we are talking about consistent results on the standard of care arm that even, let's say, when the trials were designed and published beginning of this year, are quite similar to the ORCHARD trial that was published back in 2017, and of course the CORAL trial that was published in 2010. So I think that this is also kind of interesting feature to highlight.
Excellent. No, thank you very much, Anna, and you're making my life easy, because your remark about the robustness of auto as a treatment, but also the importance of the subsequent treatments that will impact actually your overall survival, brings me to the question about actually, even if we admit today, and I think Miguel and Ola brought some, I would say, convincing arguments saying, well, probably there's no harm today to propose CAR T cells early in the history of the disease. But still, autotransplant is well established and can be useful. So could it be, Arnon, that it's simply about moving autotransplant into a later stage, as we've seen in many allotransplant indications, where you keep on doing allo, but it goes for a later stage, for more advanced disease. So what are your thoughts here?
So first of all, I mean, we did mention, I don't know if it's important or not, but we did mention that on the control arm, like 30% of the patient or more did not reach transplantation. So this is one argument that in the control arm, the patient actually did not receive the planned treatment. And also, when we give CAR T-cells, I mean, now if I try to defend more the autologous transplant, I mean, we are curing, you know, the long-term studies for both T-cell and axi-cell are 4 or 5 years, and it's 40%, 50% the most. So 50% of our patients are relapsing after CAR T-cells, and it's a big question what to do with them. Of course, if you give CAR T-cells on second line, so less patients will relapse. I think it's not logic to give autologous transplant, which is, let's say, not smart therapy. Okay, so it's not immunotherapy, it's not target therapy, it's kind of gross therapy, to give this kind of therapy after CAR T-cells. And this is one of the arguments that actually, I mean, you are losing one line of therapy, which is a good line of therapy for a relapsing lymphoma patient. Yes, where the field is moving, there is a lot of new monoclonal antibodies, drug conjugated, monoclonal antibodies, a second gen, other type of CAR T cells, you know, is better construct, NK CAR T cells, gamma delta CAR T cells, that all will be given, and you know, Revlimid and this all will be given to patients that relapse or progress after CAR T cells or have only partial response. But you know, to come with autologous transplant after CAR T cells, I mean, for me, it's not logic, and I was surprised to see the registry data that there are centers that are doing it, but I mean, for me, after this sophisticated immunotherapy to come with just high-dose chemotherapy seems not logic.
But with all my due respect, Arnon, actually, the question is not about having a fancy, sophisticated treatment or not. The question is about having a good treatment for a given patient.
Yeah.
So
I don't believe that in the patient that relapsed after CAR T cells, then the autologous transplant will be effective, because it's not just that the patient relapsed, but the disease progressed and the multi-drug resistance. I don't see that this will be a good therapy, autologous transplant, which is different than allogeneic transplant that any immunotherapy component in it. So I don't think that autologous transplant will be a good therapy if we postpone it later in the disease, you know.
I just want to follow up on Arno's comments, and I'll state up front that I fully agree with him. But the counter arguments are the following. One is, that's one reason to do the auto first, because if you do the CAR first, what do you do next? And so that's one argument that some people have made. And then the other argument is, you know, if you do the CAR in second line, those patients haven't seen platinum-based chemotherapy in most cases. And so is there still a role for platinum-based chemotherapy as salvage followed by auto transplant? I personally also have the same feelings that Arnon has, is that if you have failed CAR in second line, I'm not quite sure what the role is for auto transplant, and probably I would consider some other therapy then as a potential bridge to an allo transplant. That would be my bias, but historically I have been an allo transplant, and so you know, maybe that's why I think that way.
And the other thing, Mohammad, if I may say something, the other thing is that you may have eventually difficulties in collecting stem cells in some of the patients that have failed CAR T. So this is one thing that we have to learn. So we are hypothesizing here because, of course, patients that relapse after CAR T represent a big unmet medical need, starting with the fact that we have suddenly changed what has been the standard of care for these patients since the PARMA trial. So we need to relearn how to treat these patients if they fail CAR-T. But let's say, apart from what Arnon and Miguel has said, maybe there will be difficulties in collecting stem cells after CAR-T, and of course, after receiving platinum-based chemotherapy, which would be, let's say, the standard salvage treatment in somebody that you want to take into an auto transplant.
So, well, no, thank you very much, Anna. That was my question about to ask to Ola, actually, is that beside the sophisticated or whatever, what are the barriers actually to perform an auto transplant after CAR T cells? And you mentioned the stem cell collection issue, but this can be circumvented by, collecting stem cells earlier, at time of salvage. Someone can tell you this. Ola, do you see other barriers or other arguments in favor of avoiding, I would say, high-dose chemotherapy? And because it looks like that whether Arnon, Miguel, or Anna, they are just saying, in one way or another, that at some point, high-dose chemotherapy will die in lymphoma. And I will not cry for this, that's good news, I think, if we can avoid the burden of high-dose chemotherapy to the patient, because receiving a beam with grade 3 and 4 mucositis, 4 or 5 weeks of hospitalization, diarrhea, fever, that is definitely not a vacation. So how do you see things in the near future?
Thank you. Miguel actually pulled up one of the biggest barriers, in my opinion, which is age. Many patients will certainly age out or have significant comorbidities that makes it really difficult to pull that trigger of CAR-T, even if they are otherwise in good shape. It's still hard once they hit 70, 75. And the median age for large cell lymphoma is up there. So that would be one barrier. The other barrier that I see, interestingly, are new therapies that are coming forth. There are clinical trials that are targeting how to make CAR-T delivery safer. There are newer bispecifics that are also becoming promising. We don't know yet whether they are curative or not. And of course, receiving one type of CAR-T does not preclude receiving a different type of CAR-T. In other words, sequencing, or maybe now that we know that the existing second generation CARs will probably maybe cure half, I'm making that number up. That leaves room for things that you can add to increase that response rate that is durable closer to a higher level. So those are the things that I see as a barrier to autologous stem cell transplant. And right now, some of them already are, because the numbers of auto transplants for lymphoma in the United States are significantly lower. So that is, and the rest of these ones that I mentioned would only continue to nibble at that number until it becomes really low. Will it ever go away completely? Probably not, but I think it will be much less utilized. Thank you.
Excellent, thank you very much. Actually, we are reaching almost the end of this journal club. So at this stage, I would kindly ask one last question and one short answer from all of you about where do you see the future in this space? Miguel.
Well, first of all, thanks very much for the invitation today. It's always fun to speak with colleagues and discuss these topics. I think the future, we're already seeing it today. There are studies being performed with CAR T cells in earlier settings, Zuma 12. There's a paper that just came out with liso-cel in non-transplant eligible patients, that really actually was incorporated into the change of label. I think Ola mentioned, trying to develop better CARs or improve the CARs that we have. as well as alternative therapies such as bispecifics. So I think those are all things that we're going to see in the future.
Anna?
I don't have many things to add to what Miguel has already said. And I think that probably the future, and it's not the future, it's already a reality more in US than in Europe, is that the number of transplants, at least in diffuse large B-cell lymphoma, are clearly decreasing. Allotransplant for sure. I mean, we are almost not performing allotransplants, although maybe allotransplant will have an opportunity if we know how to manage better than now those patients that relapse after CAR-T, but autotransplants probably are going to decrease, and the field is going to be populated with more CAR-T, fancier CAR-T, and new drugs. I think that biospecifics are really very interesting. A class of drugs, they have not been demonstrated to be curative so far, but the data in terms of duration of responses are really interesting, even in patients that have failed CAR-T. So quite promising.
But Anna, don't you think that the time needed to manufacture CAR T cells today remains a barrier, and we need a quicker manufacturing really for strong and robust adoption?
Well, I think that's one of the pending issues probably with CAR-T. We know that if we have an off-the-shelf drug, this is easier to be adopted, easier to be used, no need for bridging therapy because you are giving the treatment to the patient in 24 or 12 hours from the medical decision. So this is one of the pending things that CAR-T need to do. So shorter manufacturing times, that's for sure.
Arnon?
I have not a lot to add, but just say that shorter manufacturing, we know that there is some pharma that has it already in clinical trial, and also our colleague from China. Anna mentioned that off-the-shelf allogeneic CAR look very attractive. Miguel and the paper mentioned changing in upfront treatment for lymphoma from the R-CHOP. We didn't touch on it, but maybe it will change with immunotherapy already, like the New England Journal paper with polatuzumab upfront. And also we didn't touch the very high risk lymphoma patient, hard to treat, the triple hit, double expressors. So, I mean, we need to improve there. You know, we all know the P53 JCO paper from Ronnie Chauvel and Miguel from Sloan Kettering. So there is, and all of what mentioned by my colleagues. So there is still room for improvement.
Ola?
Yes, I think my colleagues and I articulated this in the paper. We're going to see more single-arm phase 2 trials for CAR-Ts because it is just expensive and takes too long with these randomized control trials. They have their place, but we think they will be more impactful in comparing between different types of CARs rather than the same category of CARs. That's just one thought that we had. So that's just what I would add to what my colleagues, and by the way, I agree with everything else that my colleagues have stated.
Well, this has been really a fantastic discussion, guys. I really enjoyed it. I learned a lot from all of you. As usual, in these controversies, it's not black and white, but it looks to me, based on what you all mentioned, that probably the conventional historical high-dose chemotherapy is going to be ready to retire soon. And this is good news for the patient because we have now the era of immune therapy and how to harness and modulate the immune system to control these aggressive lymphomas, but also all other type of malignancies. Obviously, as it has been alluded to at the end, We didn't yet solve all the problems about the primary refractory patient, the triple hit, the high-risk patient, how to sequence all of these treatments, especially with the advent of bispecific antibodies, T-cell engagers. What are the optimal targets? But this is really a fascinating era, and it's always very good to discuss a problem, even if you don't find the right answer immediately. So I'm very grateful to all of you. Thank you very much. Thanks to our loyal audience of the ICH. I know we are in the middle of August. It's a vacation summertime for many of you. So we thank you all. We will have, the Journal Club will have its summer break, I would say, and we'll come back early September. But in the meantime, we will continue to have a few activities to make the show going on, even during your vacation, in case you miss hematology. But for the time being, thank you very much for joining us today, and hope to see you soon in a great shape. Please stay safe and keep well. Thank you very much.
Thank you.
Bye.
Bye.
Bye.